Hello, my name is Shane Clark. I'm a fourth year medical student at the University of South Florida, here to present a case from my time on my surgical rotation. Before I get into it, I would like to thank everybody who helped put this poster together. Otherwise, we'll jump right into it here. It was a primary squamous cell carcinoma of the gallbladder that we had seen. A little bit about these. They are rare cancers, accounting for about 1 to 4% of malignant gallbladder tumors. Unfortunately for these folks, they're often diagnosed at later T stages, are poorly differentiated on histology, and have worse prognosis compared to an adenocarcinoma of the gallbladder. However, the workup is the same: CT of the abdomen, TNM staging, and biopsy to clarify. And that should show your classic keratin pearls, no evidence of glandular dysplasia, squamous invasion. We can get right into the case here as well. A 66-year-old male presented to the ED with dull abdominal pain, no nausea, vomiting, or diarrhea. This pain had been going on for about 6 months, and about a night before his presentation, there was an acute worsening in his symptoms. Initially, we were concerned for an acute cholecystitis. We ended up grabbing an MRCP, found inflammation of the gallbladder. Our differential expanded to include a contained perforation or inflamed dilated cystic duct. We had plans for a total cholecystectomy. However, there was prohibitive fibrosis, and a subcholecystectomy was all that we could do. Biopsies from that case actually ended up showing our squamous cell carcinoma here. Sorry. Otherwise, follow-up PET scans, as you can see in figure F, show that the gallbladder is just lighting up. And prior to discharge, we had placed a stent under ERCP, as well as a chemotherapy port. We followed that up in clinic, started him on a regimen of gemcitabine, cisplatin, and durvalumab. However, patient responded poorly to this. We went back to the drawing board and came up with sort of where we're at now. So we decided to include Cabometyx and C1D1 nivolumab. So as for right now, that's where we're at. He's tolerating the regimen. We're titrating up and following up. Now, the discussion in this case sort of comes from why we decided to include those two drugs. Cabometyx is a known target to VEGF, c-Met, AXL, all cancer proliferating agents. And nivolumab is a PD-1 checkpoint inhibitor. There were trials that we had looked into that showed good effect, about an 85.7% response rate for squamous cell carcinoma of the bladder. So we're hoping that we see a bit of translation there. Otherwise, the cancer did end up metastasizing. Initially, it had seemed contained to the gallbladder, and if total cholecystectomy could have been performed, maybe we could have prevented the spread. But follow-up MRI that we had gotten follow-up MRI we had gotten showed a bit of invasion there. You can see it in about lobe 7 of the liver in figure E, as well as enhancement in the area of the gallbladder. But otherwise, that's about where we're at. We're trying out that new therapy and going from there. Thank you.